like electrical storm, are real moment by moment images of these excessive discharges of electrical impulses around the brain. Quite an amazing view of what epilepsy looks like inside the brain real time. So I'm going to go back to the presentation. And the causes, in most cases, well, let's say as a group, is unknown, often unknown, especially in kids. Adult onset epilepsy has more likely got a known cause, such as these. Yeah, so the ones to look out for would be some infectious cause. These are important in our environments: TB, HIV, even malaria. Not that that's prevalent in all over the country. Common one is pork tapeworm. These neurocysts. These are uh, part of the pork tapeworm life cycle, end up in the brain, causing seizures, causing cysts. And structural causes from trauma, either head injuries, MVAs, or birth injuries, strokes, brain tumors, and even malformations, structural changes in the brain. These perhaps are two commonest circumstances where there's a known cause. Then there are genetic syndromes, often in kids, polygenic mutations, and then rare disorders of metabolism, which we'll unlikely see in the workplace. Common ones we'll see unknown or these other causes. And the commonness of it is worth considering. Worldwide, about 50 million people. But interestingly, the statistics that I saw from the World Health Organization site is that there's a skewed distribution of epilepsy in low and middle income countries. So that's us. And the reason why there's a skewed distribution, in other words, most of them in the world tend to be here, is because perhaps of a lot of trauma, infections in these countries, birth rate injuries, and where perhaps medical infrastructure is not available, increasing the likelihood of these known causes in these low and middle income countries. So whereas the rate globally is about 4 to 10 per thousand, that's about 0.5 to 1%, arguably then there's a skewed distribution in these countries such as ours, where you could be looking at up to 2% of adults. And the incidence is peaks in childhood and then later on. So how do we encounter a person with epilepsy in the workplace? We encounter it in the form of these seizures, and these seizures obviously are going to vary, as we said, depending on where in the brain they happen, how far they spread. And the important thing is whether or not they cause loss of consciousness. This is, where it is of great interest to us, particularly in terms of risk. Loss of awareness, loss of consciousness, or disturbance of movement, sensation, including vision, hearing, taste, and the like, or even cognitive performance. So these are the ways they may present, either as a focal thing, generalized thing, and then this is the third category of seizure, which is just unknown onset. So the one of the presentation of interest to us is this temporary loss of consciousness, and you may be called to a person. Certainly, I've had this so many times now. Come to such and such a part of the plant, or floor 3, one of the employees has collapsed, and you rush up there with your jump bag, and you get there, and patient is lying unconscious. So temporary loss of consciousness is not an uncommon thing we deal with in occupational health, and it's not all going to be epilepsy. The commonest cause of it is going to be vasovagal syncope, a sudden pain event, an emotional stress event, and the person falls over because the vagus is overworking. The vagus nerve, and that's why it's called a vasovagal. The vagus nerve slows the pulse down, and this can happen in acute emotional distress or sudden pain. Giving a person an injection is probably the classic one we experience in occupational health. Give the person a Voltaren shot and they just fall over, and you wonder what, and it's because of a vasovagal event from the sharp pain from the needle. Other causes in the workplace, not uncommon, orthostatic hypertension. So it's a hot day. It's a security worker standing out in the heat, getting dehydrated, maybe on some medications like a beta blocker, and kaplops, they fall over. And that person has probably suffered from orthostatic hypertension. Their pulse could be up or down, depending on the cause. So I haven't described their pulse particularly, but the cardiac syncope, the other one to look for, is a person with a funny pulse. Funny pulse, in other words, there's an arrhythmia or a weak pulse in the form of a structural heart defect or even cardiac failure. So slow pulse, vasovagal. Funny pulse, arrhythmia, weak pulse, some sort of structural heart thing. And then the other important one to exclude, of course, is someone who's hyperglycemic, particularly diabetics. Look out for the telltale signs of diabetes. The person's known to be diabetic, particularly if they're on insulin. These are much less common disturbances of sodium, potassium, or calcium. So they're there for completeness sake. Epilepsy, then, if the person's known to be epileptic, clearly that would be jolly helpful. Or if there are telltale signs of epilepsy, which we'll talk about in a minute. The other one to consider is intoxication. Not so much drugs or alcohol or pure drugs, but prescription meds, sedatives the person may be put on in combination with heat and so on. So that might be a cause. The person's so drunk or intoxicated that they lose consciousness, that would be an unusual event, I think, in the workplace. Consider also potential for chemical exposure. That I think would also be unusual, but certainly life-threatening exposures to asphyxiants in the workplace can certainly cause a person to fall over and be close to death. So move very fast in the event that it looks like the person may be hypoxic from chemical exposure. TIA is a sort of a CVA, cardiovascular event, transient ischemic event, and typically if it happens in the back part of the brain, the brainstem, those people just drop, they just fall over. And they can happen if a person's got narrowing of the basilar artery in the brainstem. Person looks up to see something up on the ceiling or up on the roof. They're looking up, and in the course of looking up, they pinch the blood supply to the brainstem and kaplops, they fall over. So TIAs can cause sudden loss of consciousness. And then these unusual events, I mean, they're certainly causes of loss of consciousness, airway obstruction and hyperventilation. Those are not things we typically see in the workplace. But confined space, for sure. So hypercapnia, that's elevation of CO2, can cause a person to fall over. It's a bit like asphyxia that I was talking about here, chemical exposure. And then the other common cause, perhaps the most common cause, but the one you would get to first after excluding the others, is psychogenic. People having a panic attack or an anxiety-related episode. Certainly, that would be a common cause for transient loss of consciousness. So what do you do? What is your first course of action? Step one is always CAB, circulation, airway, breathing. Remember, it's no longer ABC. It's now CAB, start with the circulation. So check the vitals, BP, pulse, and oxygenation. If you can have one of these little oxygen measure devices, oximeters, pulse oximeters in your jump bag, do so. It's jolly helpful. And then measure glucose. So the red flags for your initial assessment for circulation would be presence of palpitations, chest pain, and if the person had mentioned a severe headache before actually collapsing. Then is this person truly unconscious, or is this just a brief faint and the person actually is conscious? You wanted to check that out. If the person is definitely unconscious, how long, and did people witness it? Because then that would be jolly helpful. If it's a witnessed seizure, that is very typical of epilepsy. Tonic-clonic movements, tongue biting, and post-ictal confusion. Those would be clues that the cause would be a classic seizure of epilepsy. Syncopal clues preceding standing, heat, emotional stress, lightheadedness, and the like. And as I said, Classic syncope, a slow pulse. It's the vasovagal one to look for. And then hyperglycemia, look for diabetic history, cardiac clues. This is the one that drops without warning, and you're looking at funny pulse or a weak pulse. And then lastly, the toxic or respiratory clues, perhaps an exposure to a chemical in that environment, low oxygen circumstance. If it's epilepsy, what must you do if it's epilepsy? Now, remember, we're not talking about TLC anymore. So basically, stay calm. People tend to get quite panicky when someone in the workplace falls over and starts fitting. Try and keep a calm atmosphere. Note the start time of the event, and then protect the person from injury. Just move harmful objects, cushion the head, support the breathing, loosening tight clothing and the like. And, protect the dignity of the person. The person collapses, and it's often in full view of everyone else in the workplace. Try and provide some sort of shield or privacy, if possible. Then just observe, watch the seizure type, duration, characteristics, and stay there until the person's fully awake. What you shouldn't do is, sit in the person and hold them down so they don't move. And importantly, not to put anything in their mouth. It's often a temptation. The person is clenching and appears unable to breathe. You want to now shove an airway into that person's mouth. It's not a good idea at all. And do not give the person anything to eat or drink or take until the person is fully awake. Wait until that post-ictal confusion is fully complete before offering anything of this nature. And CPR may be necessary in very, very rare circumstances, but don't consider such a thing unless there's a no pulse, no breathing after the seizure. Then you may need to consider CPR and then call the emergency medical services. So post-recovery, just sitting with the person, keep the airway clear, reassure the person, reorient them, often very confused after a seizure. Check that they've hurt themselves or not. They may have bitten their tongue, bitten their lip or cheek, or they may have fallen over and bumped their head. So check for injuries and then allow them to rest. They recover generally and stay there with the person and fully alert. And then typically let them go home. We wouldn't let them carry on, stay at the workplace. Reasons to call emergency medical services if the seizure lasts long, 5 minutes, and you already are looking at status epilepticus. So long seizure, second seizure happens. If it's the person's first seizure, no known cause, that would be a reason perhaps to get emergency services in. If the person is pregnant or becomes so injured by the fall, or maybe the injury is the cause of the seizure, so injured, significant injury, that is, someone who's diabetic and someone who's pregnant. These are risk factors that warrant perhaps the paramedics to be called and maybe sent to hospital. And of course, as I mentioned just now, if the breathing or heartbeat stops, then CPR and call the ambulance. So now we're into the workplace risk discussion. If you're now doing a risk assessment and you're deciding, can I deploy this person to a particular workplace? What are the factors that we'd want to consider? We've got some person factors. So, what are the actual seizures? Is it a whole loss of consciousness? Or is it just motor control or sensory input? Perhaps just a weird sensation or impairment of vision. So those would impact the degree to which this person is incapacitated by these impairments, how often they are, and this important one here, the absence of a warning aura. Now remember, an aura is what the person experiences just before the seizure happens. And this is something that happens with epileptics, not always, but commonly. They get a feeling something's wrong. Sometimes they get to know exactly if a particular feeling happens. They feel nauseous, or they feel dizzy, or they feel something like ringing in the ears, a tense sensation, a taste. That's a warning. And it says, I'm about to have a seizure. And if they have a warning, they can then find a safe place and then have the seizure in a safe place. So that's an important one. No warning aura increases the risk factor. If the underlying cause is persistent, like a tumor or a CVA or something, then that increases the risk because the likelihood of this going away is then very, very small. Also, means there's always an imminent possibility of a seizure taking place. If there's a medication problem, poor compliance or constantly changing meds, that would be a reason to be cautious about that person. And if they break through seizures, despite being on meds, then that would be a risk factor to consider. And then the workplace is where we typically focus our risk assessments at. So there could be safety-sensitive tasks. These are the obvious sorts of things that we think about. Hazardous equipment, such as a chainsaw or a drill or the like, or driving hazardous mobile plant equipment, forklifts, diggers, loggers, loaders, or any other driven vehicles. I mean, there are many versions of that, trucks and so on. And then a safety-sensitive spot or location. So working at height is a safety-sensitive location, especially if there's fall risk. And this one is a common reason to consider a restriction. So we need to think about working at heights. Remember, working at heights isn't just being above the ground. It is a circumstance where there's a real risk of falling. And typically this would warrant wearing a harness to protect the person from falling. So epilepsy is of real relevance, of course, where there's a fall risk, but not necessarily just because the person is working on an elevated platform. We must very carefully consider what working at heights means. It must include a risk of falling. Then working in confined space, you don't want a person who's at risk of losing consciousness in a place where there's a possibility for asphyxia or hypoxia. Remember, confined space isn't just a closed room, it's a confined space typically where there's a risk of low oxygen levels developing. Working near deep water, person might fall in and drown, so beware of large expanses of deep water or dangerous heat sources if you're working next to a molten metal or the like, or very hot surfaces. That would be a location where a person with epilepsy should probably not be working. And then places where there are seizure triggers like flashing lights, stroboscopic lights, and if there are long work hours where fatigue may set in. Fatigue is a trigger for seizures. So high stress, high fatigue may be a caution for someone who has epilepsy. So in the risk formula, we remember risk is all about severity and the probability of the event happening. So some severity factors would be, what are the consequences of the person having a seizure? And for that, you'd need to consider how hazardous is the equipment. Can this equipment cause serious harm, or are we overreacting? So seriously harmful equipment, high severity. And then the location, fall risk, water risk, and heat risk, and the like. How high, how deep, how hot, and so on is going to give you your severity score. And you could even score that out of 5 and say 1, 2, 3, 4, 5 in order to give you a calculation. And then on the probability side, there are these workplace probability factors. How often and how long does this employee actually perform safety-sensitive tasks? If this person, for example, is a workshop artisan and from time to time gets asked to go up on the roof to go and do some roof work, you don't want to necessarily say, hey, you're unfit to be an artisan because you can't climb the roof twice a year. So how long and how frequently that person's performing the safety-sensitive tasks that you're worried about would influence your probability side of your risk equation. And how likely is the person to come into contact with a hazard? If it's, for example, moving forklifts, moving around the workplace, you're worried the person might fall over and get ridden over by a forklift. I've had that, by the way. It's one of the cases at the end where they said, no, you can't work there because what happens if he gets ridden over by a forklift? So how likely really is that to happen? Is the forklift operator unable to see in front of him, and therefore go crashing into the person with epilepsy? So give some thought to the likelihood that this hazard of concern is going to come into contact with a person who's lost consciousness. And how difficult is it to avoid the hazard? And more difficult to avoid the hazard, the higher the risk, the higher the probability. And the person probability factors, how likely is it the person's going to have a seizure? And this is perhaps one of the things we battle with most around fitness to work. This likelihood typically is a clinical decision, and we look at the cause. Is this a persistent cause that might trigger another seizure at any time, like a tumor or a head injury? And also, when did the last seizure happen? How long has this person been seizure free? And this is a formula you'll see often. We'll come across it shortly. Do you need to have the person off for 6 months, 12 months, 5 years, 10 years? The logic behind this is that the longer you've been seizure free, we know from many, many years of research, the longer you're seizure free, the less likely you're going to have another seizure. So if you've been seizure-free for 10 years, you're pretty much at the same likelihood of a seizure as everyone else in the population, down to about 1 to 2%. How responsive are you to meds? How compliant is a person to meds? And, the actual nature of the seizure itself. Those are all factors that you're going to put into your formula to decide if a person's fit or not. So let's have a look at some of these guidelines about how long must the person be restricted from safety-sensitive work. And I've summarized many pages of complex writing. So please bear in mind, this is really, really very simplified and summarized. But the SASOM driver guideline separates light motor vehicles from the sort of more heavy-duty motor vehicles. And this is how they view the period of restriction. And it's a guideline. This guideline is based on figures given to us from the United Kingdom, which are recognized, in fairness, recognized to be quite strict. So if you're driving a light motor vehicle and you have unprovoked seizures, remember more than one, can't just be a single seizure, then you should be seizure-free for at least 1 year. Unprovoked seizures. Remember, those are the ones where we had no obvious cause. They have a thing called a permitted seizure. Permitted seizures are by pattern, in other words, during sleep, or there's no impaired consciousness or no inability to act. The types of seizures where you can actually still move and you actually are aware, even though other factors are taking place during your seizure. So it'll be a rare type of seizure. Seizures during sleep are not that uncommon. They're limited to sleep only. Then that would be a permitted pattern. And if you have a permitted seizure, then you only need to be seizure-free for 6 months. And another one, by the way, is medication. So if you're on meds and they fiddle the meds, then while you've had meds fiddled with and changed and you had a seizure, then the meds were corrected and no seizures for 6 months, then you can get behind the wheel again. So medication adjustment, had a seizure, meds were fixed, 6 months later, you can drive. So that's light motor vehicle. If you have a single seizure with no underlying cause, right, then you're in the 6-month space. If you have an underlying cause with a single seizure, let's say head injury, then you shouldn't drive for a year. So this is SASOM driver. Now, bear in mind, this is a recommendation for vocational driving. This is not driving in your private capacity. That we leave up to your neurologist to decide. These guidelines are based on someone who's employed to drive. So I know some neurologists look at these and say they're too strict. The reason is because these are for people who are driving as part of their job, and therefore there are all kinds of vicarious liabilities attached. So that's the SASOM driver guideline for light motor vehicle. Now look at this for driving a bus or truck. There it starts to get really quite severe. Unprovoked seizures here, 10 years, and no meds. So you have to be off your meds, no seizures for 10 years. If you had unprovoked seizures, if you had a single isolated seizure, 5 years of no unprovoked seizure, also off meds. So this code of driving is deemed a very high risk code of driving by SASOM and the United Kingdom's driving license authority. So that's why these are really quite strict. The more general guideline, again, in SASOM as a more general safety-sensitive work guideline. And they, interestingly, they just say if you're seizure-free on no meds, you're aware 1 year off safety-sensitive work, you're on meds for 2 years. So it's a 1 year, 2 year rule, assuming that the neuro is normal and you have normal EEG and the like. So this is a general rule you'll see in the SASOM safety-sensitive guideline. Probably quite commonly used. I know some neurologists would say, hey, seizure-free 6 months is good enough. The guideline here is 1 year, 2 years. Now, interestingly, if you look at other authorities like the United States National Fire Protection Association, they have a simpler view. Again, I've simplified things tremendously here. But seizure-free no meds, 1 year, similar to SASOM's seizure-free no meds. But because these are firefighters, if you're on meds, then they want you to be seizure-free for 5 years. So not massively different from the SASOM general guideline. Point is, nowhere here does it say 6 months. And I know some neurologists might say, oh, you know, happy you can go back to work after 6 months. So let's go on then to talk about certification. This is a quick reminder, what is certification of fitness? And how does it talk to inherent job requirements, and where does epilepsy sit in this? So is the employee capable of performing the tasks required is half of the equation. The second one is the employee required to work in conditions that are going to potentially be a risk? So can the person do the work to the required standard and safely? Okay, so there typically is where we're interested in for epileptics. Can they do the work to the right standard of quality and effectiveness? And that's probably absolutely fine. Epileptics should be able to perform perfectly well there, but they may have a problem with safety. And what about the working conditions, such as chemicals or heat or dust or the like? Well, they may have vulnerable conditions. They may be deemed to be a vulnerable condition here, so bear that in mind. So an epileptic may trigger that in terms of a reason to influence a decision about fitness to work. So ultimately the question is this employee able to fulfill the inherent job requirements? So these are, in fact, the job requirements. Let me just click on there again. There. So these are the inherent requirements of the job, to be able to perform these tasks to these standards and safely and in these working conditions. And the inherent requirements of the job are defined in the Code of Good Practice. Essentially, it's all about the essential job functions. So you need to decide, when you're deciding fitness to work, does this person meet the inherent requirements, meet the medical standards required to fulfill the inherent requirements of the job? That's the decision of fitness to work. And epilepsy may touch on safety and may touch on the vulnerability. So when you adjudicate, you're going to say the person's either fit or not, plain and simple, or you may need to apply certain conditions. The person has to wear glasses, or has to wear special boots, or has to do something like that. But there's no incapacity here. The person can do everything in the job. There's no accommodation necessary. The moment the person has restrictions, now there's incapacity. Now there are special measures that have to be taken. And that would be probably where an epileptic is likely to trigger some sort of a requirement on your certification, that there may be restrictions on task or place. But remember, no generalization. So when you're dealing with an epileptic, you don't say, oh, the person's epileptic, therefore something needs to be restricted. Apply your mind to whether that epilepsy, those seizures, are actually a real risk and a real impact on the inherent requirements of the child. Finally, then, is it a disability? We've now concluded that it might be, in fact, an incapacity, that it impacts the performing of the inherent requirements of the job. But a disability, in terms of the Employment Equity Act, gets slightly more complicated. It looks very similar, but can be slightly more complicated. And if some of you have been involved in these, you may appreciate how sometimes we can get ourselves all tied up in these decisions as to whether or not something is a disability. So let's look at how the Employment Equity Act defines people with disabilities. So this is a copy and paste straight out of the Employment Equity Act. with this new, by the way, there's been an amendment to the definition now recently, April. It was first promulgated in 2022, but in fact, it was signed off only earlier this year. People who have people living with disabilities are people who have a long-term or recurring physical or mental intellectual sensory impairment. So the impairment is the important feature here. Something is impaired by way of physical, mental, intellectual, sensory function. That's an impairment, which is long-term, that means 12 months or more, or recurring, which means it relapses. So those are things we're quite comfortable with in certifying an occupational health, I mean, long-term recurring and these impairments. So of course, epilepsy would sit comfortably in the space of long-term and recurring, and it's a physical, could even be a mental or even a sensory, could even trigger several of these impairments. Then the important and the most difficult part of it is, what about substantially limiting? It has to also be substantially limiting in terms of their prospects of entry into or advancement in employment. And that's the one that creates difficulty. Does it indeed constitute a substantial limitation? Now, curiously, in the Code of Good Practice, they say this: if you want to know if something is substantially limiting, okay, this is what it is. They give three versions of what substantially limiting is. Now, curiously, they only really give one what it is, and then they gave two of what it's not. So 5.1.3 of the code says that it is limiting if in nature and duration, it limits the person's ability to perform the essential functions of the job. Now, we've just seen that in your certification of fitness. So if there's a restriction on the ability to perform the inherent requirements of the job that is being considered, then that is what they call a disability. Now, that's in fact an incapacity. And so it's basically when there's a restriction of the person's ability for the job being considered. And you may have a certificate of fitness that said this person's restricted. So that's what it calls substantially limiting. But I think that's a very limited view of what substantially limiting was intended to be in terms of the EEA. These other two, straight out of the code, remember, are basically saying if the impairment is easily controlled, then it is not a disability, like wearing glasses or treating hypertension. That's not a disability. And you must also consider if treatment is going to control the problem. If treatment easily controls the problem, then it's not a disability. So in its definition, and the code's definition, it really limits the explanation for substantially limiting to essentially an incapacity. And so the question then is, if a person with epilepsy applies for an office job, okay, can perform all the essential functions of the job, so tick, would they be classified as a disability? Now, according to this, it wouldn't be, because the person can fulfill these essential functions of the job absolutely without a problem. You could arguably say the same thing. What if the person's blind in one eye or amputated lower limb, and many other impairments would probably not be substantially limiting in terms of this definition, but probably wasn't the intention of the Act. So we need to think about then, well, what do we do? This is a little table that I discovered at the back of the Employee Equity Act 1 form, the EA1 form, which I assume many of you are familiar with. If you don't know what it is, it's the Department of Employment and Labor has this form, front and back, on which the employee who is comfortable to be declared a person with disability then can fill in and sign. And employers really would like employers to fill this in if they do meet the requirements of a person with disability, because it helps employers to comply with the Employment Equity Act's essentially quotas of people. Employers must employ a certain number or proportion of people with disabilities. So employer is very happy if the employee says, yes, I have a disability, and fills in the EA1 form. And they fill in a page at the front, and then there's some explanatory notes at the back. And this is a table at the back that says, by the way, some of the more common or known conditions that are considered to be disabilities are these. And then it lists diabetes, cancer, deafness, partial loss of hearing, chronic fatigue, and asthma, even heart disease. So some of these are very non-specific. They're epilepsies. So arguably epilepsy is in the list, but all these others are non-specific, and they don't really talk to the question of whether or not these are all impairments, um, rather than disabilities. They only become disabilities if these impairments become substantially limiting. So in a sense, not that helpful, but I think it gives us this, maybe the sense that what the Department of Labor was trying to do was reduce the barrier to people with with a variety of impairments, and call them disabilities. So after much discussion, and with this, inputs from occupational health nursing colleagues and HR people, sort of concluded that you need to consider that part of the definition that said it's substantially limiting if it impacts the person's prospects for going into another job or advancing in their own sort of field of jobs, so advancing in their own jobs or getting to another job altogether. If there's going to be a, a reasonable possibility that this impairment is going to harm the person's prospects for entry into another job which this person is reasonably expected to apply, or even advance in other jobs. Now, for this, we in OH may not be in a position to answer. I've concluded that I would need HR to say, listen, here's this impairment. We need consent to have this conversation, of course. It's not impacting the person's job in which they are or in which they're applying to be, because it doesn't prevent them from fulfilling the inherent requirements of the job at all. But what if they want to progress? Where would they be reasonably expected to apply? What other types of jobs? Or if this person applying, where would they otherwise also be expected to apply for a job, and would this impact them? So a person who's applying, for example, for an office job, could they be reasonably expected to progress and say, I want to now work on the floor, I want to go into the operations, I want to become involved in operation, and I may need to work at heights, I may want to operate a forklift. Would these then be impacts that would prevent the person's prospects? And then that would open a lot more opportunity for classifying a person with disability. So not just own job, which is this one here, their own job, which is the definition as per the code, but for any other job for which they may be reasonably expected to apply or progress. So take-home messages in the last few minutes is, remember, it's not uncommon. Seizures can be a risk in the workplace. They typically present as a loss of consciousness or person has collapsed. And determining fitness to work can be tricky. Typically, we need to do a risk assessment. What are the probabilities and severities related to the workplace? Do not make golden rules about those. And then what is the likelihood of a seizure to take place? And that's commonly based on the cause and the last seizure that happened. And do not unfairly prevent people with epilepsy from accessing jobs. Balance the risks and allow the person access to work. And I'll talk about these cases if there's time, but perhaps let's first take questions and answers. I see there's people have joined this talk since 60 people on the group all of a sudden. Hello, everybody. There weren't that many when I started.
I don't see any questions. If you just look in the chat. No, I don't see any questions. You're welcome to do the cases, and then if there's any questions, I'll post it afterwards.
Okay, so here we go. You may even know one or two of these. Well, you know one of them. So here's a 28-year-old general worker with epilepsy in a pharmaceutical plant. So that was a person who had a seizure in this plant. It's one of those magnificent places, clean passages, super sophisticated working environment. Person had a seizure, and the roof manager was concerned and felt the person should probably not be fit to continue working at the plant. And you look at this and think, hang on a minute. So we did a risk. I said to this risk manager, listen, I think let's do a risk assessment. And one of the questions I put to the risk manager, who was very proud of his plant, by the way, and very proud of his very low rate of injuries and IODs, and asked him, well, what is it about your safety prevention or your injury and safety measures, injury prevention safety measures, that would allow such a person to actually become an IOD, apart from just falling over and bumping his head. And after a conversation with the risk manager, it became very apparent that this plant has an excellent safety record, excellent prevention measures in the workplace. So a person who falls over, a general worker who falls over, not operating hazardous equipment, really is not a reason not to allow the person to return to work without. Obviously, we want some reasonable measures of preventing these from happening. You don't want seizures happening all the time, but the occasional seizure had almost no risk really of anything beyond the person just bumping their head as they fell over. So that was case one, and many of you this may resonate for you too. Here's a person in a sawmill. Now, here's a sawmill, a large hazardous saws chopping up trees. And this is a general worker again, and the general manager this time. Yes.
Sorry, we can't see your
Oh, my
presentation.
goodness. Thank you. I've just realized I forgot to share. Fortunately, none of the stuff really mattered because it was really what I was describing. So there's no thing more than just prompts to me. So this is the 28-year-old. Can you see this?
Yes, we can. Thank you.
Good. Thank you.
We were just worried you were talking as if it's something we should see.
Right. Thank you. I was being a bit slow. Thank you so much, Joe. So as you can see, there's just prompts for me, and I'm telling the story from a real memory. So here's a person, general worker, a known epileptic, had a seizure at work. And the general manager said, Greg, this guy, surely he's not fit to work at this plant. It's a sawmill, big machines, these things can chop people into tiny pieces. And they're roving forklifts going around all over the place. If this person falls over, the person could be severely injured by a forklift. So again, we decided to go and take a walk and have a look. And this person was working in a part of the operation area that was quite a long way from the saws. In fact, the products, the saws chopped up, which was basically planks, got down the production process. And this person was working where these planks were being stacked and turned into sort of kind of palletized stacks that were strapped and then sent off to the market. And the general worker's job essentially was just marking the pallets and writing on them and putting, stickers on them, etc. So the likelihood of an injury from falling over was certainly more than in the pharmaceutical plant, but still very, very low. It didn't climb on the pallets, didn't work at heights. And if there were forklifts moving around, there certainly were, obviously, amongst the pallets, then there was a possibility that the forklift could drive into the person, but extremely low probability, unless the person literally jumped out into where this person was working, by the way. The forklift operators didn't actually go there until he was finished with the job and left, and then they would go and perhaps pick up the pallets afterwards. So we concluded that probably the risk was tolerable, but certainly we want the person's epilepsy to be as well controlled as possible. If it became uncontrolled and frequent, then the risk might in fact exceed the safety tolerance, and then we may need to restrict. So sort of escalating from a very posh and clean pharmaceutical plant to a more rough sawmill environment. And yet this particular person, I feel comfortable to certify fit. And then this one was a general worker working in a laboratory setting, not quite as clean and shiny as a pharmaceutical plant. Pretty, it's a research laboratory in a high-tech research environment, well, in fact, medium-tech research environment. And the job of this person, this general worker, was essentially to clean the laboratory glassware. So, there are lots of tubes and containers and pipettes and other glassware used in these labs, and they get used for a particular process. Once the process is done, they get all disassembled and put into a cleaning tub, cleaned up manually sometimes, and then dried, carried back into the store for that glassware. And this person was the cleaner of that glassware. We did a risk assessment, had a careful look, and I was, in this particular case, felt that indeed this was a situation where the risks were actually too high and redeployment in another safe environment was necessary, because the glassware, if the person did have a seizure and was carrying glassware or working with glassware, could easily crash and have all that glass land on top of him. So in fact, it wasn't even, it was a lady. So I restricted her from working in the lab, well, certainly was from cleaning laboratory glassware, and preferably not to work in that lab. It was a very active research environment, and perhaps it would be better to redeploy somewhere else. So those are just 3 cases that can perhaps get some conversation going. And so I'm going to stop sharing again and back to the group. And looks like I've escaped today, Joe. 3 minutes to go, no questions.
Now flabbergasted.
They want to get on with the meeting.
Any questions? Now's your time to ask.
I see some names that I know. Hello, colleagues. Those of you I know. I see there's a hand up, Robin de Vet. Yeah.
Okay, I don't see the hand, but let me just unmute her. Robin, just hang on a second. I'm trying to wade through everybody. Okay, you may unmute yourself and ask your question.
Hello, everybody. Great, thank you. So interesting. I think our biggest problem is often the OMP or the risk and safety people often being overly cautious and trying to have these logical conversations about, well, what is the risk? And you put it so nicely, you know, if it really is a situation where if you have a seizure in this environment, the risk is just too high. But there's multiple sectors where a person could have a seizure and it actually have very little impact. I wonder if you would maybe just clarify the IOD aspect of it, because it is every time I want to say the cause for consternation, because the injury, you know, it's not an injury as a result of it wasn't a slip, trip, and fall. So it was a primary healthcare condition that the person themselves has. And it only is, in my understanding, when the person has a laceration, that this would then be, the laceration would be the IOD. What we've had issues with in the past was with the doctors at the hospital, whatever, because they're not supposed to treat the medical condition, they're only supposed to treat the IOD aspect. And the stats, and everybody that gets like really uppity about that, as you know. Thank you.
Okay, thank you. So in the few seconds remaining, that if a person becomes injured at work for a reason which is a primary healthcare reason, then you're quite right. The actual reason is not part of the scope for which the COID would cover. The COID would cover only the consequence. So if the person has a TIA and loses consciousness with a hypoglycemia or anything like that, and then falls over and bumps the head, then the bumping of the head is the injury, and that's what gets treated by COID. You know, I suppose sometimes it becomes a fine line between the person falls, bumps their head, it's diabetic, had a hypoglycemic event, fell over, gets sent to hospital, and in hospital they get treated for the diabetes and for the bump in the head. I suspect COID will cover, you know, the entire treatment. It's quite hard there to separate. Hang on, wait, we're only going to pay for the part of the bump in the head, and the diabetes part we're not going to pay for. But in theory, that would be, you know, the distinction between what's COID and what's not COID. And we find this, for example, even with HIV. If you have a needle stick injury, the HIV treatment and at least prophylaxis isn't covered, but the needle stick is. So if you can needle a plaster, COID will cover that. but if you if you need serological tests, COID won't. So these are subtleties, and I suspect that COID is not a hard and fast going to apply those rules. The question, of course, is company stats. And that's when we all run out the room shouting and saying, talk to someone else. But company stats, would then need to try and decide, is this a reportable in terms of internal company stats, or is it not reportable? And by that, they usually rely on, did the employer have some control over this? Could the employer reasonably prevented this? And that again becomes a debate, because the employer might look at you and say, hey, why didn't you reasonably prevent this? Or could you have reasonably? Yes, you could have done a medical and prevented this person from having a seizure, which of course is nonsense. No medical is going to predict and prevent a seizure event. So my sense of statistics is that you need to look at each of the company's rules around what is deemed employer responsibility and employer preventable versus that which isn't. And if it's not really preventable, then arguably, or predictable, then arguably the employer shouldn't be held accountable, or the stat shouldn't be held accountable for that event. So the person who had a seizure, fell over, bumped their head, needed laceration sorted. It's a COID case, arguably not a statistic in the company. I hope I've covered your questions. Okay. Over to you, Joe.
Thank you very much, Dr. Greg. That was a very insightful presentation. And yeah, epilepsy is always a problem. We had 3 cases last year in the space of 3 months at one farm of 3 people with status epilepticus who had never had epilepsy before. Yeah, no, it was a mystery. And that was the first and only time they ever had that. Anyway, so yeah, it's always been a mystery. But thank you very much. We've enjoyed listening to you very much.
A pleasure.
All
Thank you,
right.
everybody. Good luck with the rest of
Good.
your meeting.
Thank you. To you too. We hope to speak to you again soon.
Okay.
Goodbye.
Bye-bye. Bye.
Okay. Let me just share my screen with you so that I can get on with the meeting. Takes a while if you share PowerPoint from within. So just bear with me for a little bit. Okay. So the next one, we are going to look at triage, and I've taken a shortcut today. I want to play to you a very nice video about a South African triage system that they use in the government clinics. I feel it is a little bit more appropriate to what we do in our clinics if you do primary health care. So listen to this. Please let me know if you cannot hear. It is a setting on the computer which I think I've enabled. Yes, it's enabled. So please let me know if there's any problems if you cannot hear. Dorothy, can you hear the video playing?
No, I can't hear.
You see it on the screen, but you can't hear.
Yes, I see it on, but I can't hear.
It's not playing on my screen. Nothing's playing.
Okay, let me just go back. I'm going to share the window. I'll try another way. Just bear with me for a second. I just want to copy the link to the video. Can you hear it now?
No.
Still not. Okay.
You
I'm
need
going. Yeah.
maybe a suggestion. Maybe if you put it on and people can play it on their own side and open it and it will play, because I tried to open it from my side on the other window.
Okay, just hang on a second. I'm going to try one last time.
An emergency center. Many deaths in hospital occur within 24 hours of
It's
admission.
playing.
Okay, wonderful. And you can hear it. Okay. Good. Let's start over again.
What does this mean in the context of an emergency center? Many deaths in hospital occur within 24 hours of admission. Some of these deaths can be prevented if very sick adults, and especially children, are quickly identified on their arrival and treatment is started without delay. In many hospitals around the world, children are not checked before a senior healthcare worker examines them, and as a result, some seriously ill patients have to wait a very long time before they are seen and treated. Children are known to have died of a treatable condition when waiting in the queue for their turn. The idea of triage is to prevent this from happening. So the word triage means to sort, based on medical urgency. Let's take the example of a waiting room where 5 patients arrive and the emergency center nurse triages them using a scientific triage scale, in our case the South African triage scale. She's able to prioritize the urgency of the patients, and therefore the patients that arrived are not seen in time order but rather according to medical urgency. The end result is that the patient with the greatest need is helped first, and we are able to prioritize limited resources to achieve the greatest possible benefit. However, as more patients arrive and are triaged, the non-urgent green patients move to the back of the queue and end up waiting, sometimes for a very long time. This can be problematic because it increases the load of patients in the waiting room and increases the likelihood of missing a very sick patient. So in contexts where there's a mismatch of demand and capacity, the purpose of the South African triage scale is to prioritize those who need to be seen first. Let's talk about some of the structural requirements for triage. All you really need is a location and some equipment. Your location should be safe and should be accessible to someone in a wheelchair or a stretcher. It should be large enough to fit a desk, chair, as well as some equipment. Safety is imperative. Your equipment would include gloves, face masks, other barrier protective devices, a wall clock for respiratory rate, low-reading electronic thermometer, electronic blood pressure and pulse analyzer, Dynamap or digital, with a pediatric cuff if possible, and some dry dressings and bandages. The South African triage scale has 2 versions, one for adults older than 12 years or taller than 150 centimeters, and one for pediatrics younger than 12 years or smaller than 150 centimeters. Each of these versions have got 3 important components: clinical discriminators or signs, physiology, the TEWS as a composite score, and then some key additional investigations. Each of these 3 components allows us to categorize the patient into their appropriate priority level. Red would indicate an emergency to be seen immediately. Orange, very urgent, should be seen within 10 minutes. Yellow, urgent, can wait up to 1 hour, and green, non-urgent or routine, can wait up to 4 hours.
Hello everyone, welcome to the next module of the ETAT training course.
Okay, that's it. It was a very short video on triage, which I wanted to share with you. This is triage in a primary healthcare setting. those of you who work on the farms and see large amounts of people in the clinics may make use of this. I've pinned the chart for you in the chat setting. It should be right at the top. And all that we basically need to do is take the blood pressure and the temperature, especially now going into flu season when the people do get really sick. And that chart will tell you whether it's an emergency or so on. At our clinics, we do screen the people coming in. We've trained our clinic assistants to help us with the screening, but it doesn't help us doing the screening and they don't know what to do with the results. So something like this tells them how to act, what to do when they see the results. Let the patient see the sister next, or interrupt the sister when she's busy with the patient to say there's somebody that's very sick, you need to see them now, or let the person wait if there's somebody that's very sick that needs to be seen next. So this really helps if you do primary health care in your clinics. Let me just share the presentation again. I'm sorry it takes a little bit of time. We're almost done. I hope that it has helped you. Trauma triage is slightly different. If you want to know more about that, we can share that with you going forward. Okay. So with the minutes of the previous meeting was shared on the group chat. I will include this with the Teams meeting as well. Is there anybody that wants to propose the minutes for us, please? I can't see you raise their hands. So anybody? Kathleen de Villiers. Thank you, Kathleen. Anybody who seconds it? I'm unable to see like a non-committee member to second the minutes for us, please. Yolandi Jooste. Kathleen to propose the minutes. Sorry, I'm just writing down. And Yolandi seconds. Thank you very much, Kathleen and Yolandi. Adele, I hand over to you to do the report on the finances. Thank you.
Hi, good day, everyone. Our last month's financials, closing balance is standing on 181,857.05. We've had a workshop last month, and our profit, our expenses for the workshop was 48857, and the income was 633,880, which gives us a profit of 15023. So I want then, to conclude, the finances is looking in a good position, and thank you to all our members. That's all for financials. Am I going straight over to marketing?
Just let's just get somebody to accept the financials. Someone to accept it. Kathleen de Villiers accepts the financials. Somebody to second it. And Yolandi Jooste to second it. Thank you, Kathleen and Yolandi. We appreciate that. And Adele, you can go over to the marketing. Thank you.
Okay, thank you, Gionette. The marketing, you see a slide with all our exhibitors that participated in our workshop. It is thanks to our exhibitors that we had such a wonderful profit. Without them, we would have just been playing equal. So I just wanted to highlight on the top left, we've got AVA, which is a software company that you can use for your primary health care. They are the future with AI, where you would have like this equipment of them, and you can sense, or the equipment will sense what vitals and even your ECG or many other applications, and then a doctor can remotely help you with the diagnosis and treatment, and they will give you a script, or it is very helpful for the future and for especially remote clinics. And then in the top right, we've got a paramedic shop. The paramedic shop has been around for many years. They are a staple company to use for your bandages, your plasters, your AED equipment, for your jump bag, for your first aid equipment, anything that you can think about first aid, but also your glucose strips, your gloves, and like I said, your bandages that you might need in your clinic. And then we've got in the middle Ampath, which is our pathology, very knowledgeable, very helpful with occupational health. And then in the lower bottom, you've got Pathcare, also our reliable and always there for us exhibitors. I can.
Adele, you've disappeared. We've lost Adele.
Yes.
Oh, there you
I'm
go.
back.
Okay, good.
Clinic Sister. They are a software program. They are fantastic for your for the future as well. We're going to go digital for your check, for your risk assessments, and for your primary healthcare and your occupational healthcare, to plan your medicals and to have a software program where everything is all together. And then SSEM, I've been using them for many years for my cocoa. Sorry, I'm seeing. Okay, I'm almost done. SSEM, I use them for my cocoa spirometry and my filters. And then in the same breath, MED is a company from Joburg that flew down to introduce to us that they also got a bacterial filter, which is very competitively priced. So it might be useful to look into that as well. And then last but not least is Diabetes SA. They were there as an NGO to make us aware of the benefits of being a member if you've got diabetes, and they've got lots of resources to help us in our clinics. And that's it. Sorry for all the losing and then rejoining. That's it. Thanks, Janine.
Thank you, Adele. It's fine. The weather is not cooperating today, so we understand. Lindy cannot be here with us today, but she has left us a recording of her presentation. If you hang on a second, I am going to just share her recording with you. Okay, I've got it here. I just need to make sure that you can see it. Okay, so in a second, just want to make sure that you can hear it as well.
Good afternoon, everybody. Good afternoon, everybody. Sorry that I cannot attend.
Dorothy, can you hear it?
I can.
Thank you. I'm going to go ahead with it.
The meeting this afternoon, but here with my feedback on my portfolios. I want to start to give you a little bit of feedback on our workshop held on the 28th of March. It was called the Balancing Act. And the reason for that is that we as an occupational health practitioner is one of the most important members in this multidisciplinary team that needs to ensure the health and safety of our employees. The idea of the workshop is to start from the OREP, ending with the medical surveillance, and how do we actually attend to these employees. We had an employee as a case study, a truck driver transporting hazardous goods, in this case chemicals. He was also the appointed first aider and suffered from a chronic disease. All the attendees were divided into groups and had the opportunity to ask the employee questions to complete the OREP. Thereafter, we looked a little bit on hazard identification and risk assessment versus health risk assessment and a couple of ethical components with regards to that. After tea and lunch, we had Kim Davies, Fanny Creer and Wendy van Wyk, who spoke on all the different hazards. And then Dr. Heidi Williams spoke on occupational health medical surveillance and reviewed the OREP. Thank you for the positive feedback that we received, stating that they loved the holistic approach, the clear explanations, loved the interactions, received valuable information, and gained knowledge on the day. Our Kahoot winner was Hanli Brewer, and a lot of positive feedback with regards to the quiz and the interaction and being interactive. I would like to take this opportunity to thank our exhibitors and sponsors. Without you guys, this day is not possible. We really, really appreciate you guys. On the day, we announced two winners, Sister Marianne Klute and Sister Hanli Brewer. Sister Marianne Klute was the person that first paid for the workshop, and then the random second person who paid before the due date also got the same price, and both of them have free entrance to our workshop in August. So well done, guys. Thank you for your support. This brings me to our year plan. Please note there was a change. Our kaleidoscope in June moved to August, and our mini virtual workshop in August moved to June. The August date is the same. The June date changed from the Friday the 27th to the Wednesday the 25th. And that will be an online session on mental health. And August will be about fitness to work. And we will have various speakers that will be face to face. Our May meeting is on the 28th of May is our next general meeting, and it will be on a respiratory impairment as our educational topic. Looking at the health calendar, on the 10th, I would like to challenge you guys. There's a global move for Health Day. Let's see, can we do 5 or maybe 10,000 steps on the day? Let's challenge each other and let's get moving. On the 12th of May, it's International Nurses Day. I hope you have got something special planned. And then the 17th of May, World Hypertension Day, if you would like to do something for your employees. We all know that we have a lot of employees suffering from hypertension. And the 31st of May is World No Tobacco Day. Upcoming courses for Health Science Academy, May and June, we've got Audio Spiro Vision, and there's a dispensing course. And then there's refresher courses, Audio and Spiro, and then that will be online. For Education for Health Africa, we have Audio Spiro and Vision short courses every month, as well as refresher courses for Audio Vision, Reproductive Health, and Spirometry. Guys, I'm sure you also know about the new noise exposure regulation. It came into effect or were published on the 6th of March. It has an 18-month implementation period, so it comes into effect on the 5th of September 2026. There are some major changes. If you have not read through the noise exposure regulation, I do recommend that you do download it. It obviously is free of charge on the internet, and read through it. We will be discussing the changes at on some other platform in future. Then with regards to our student affairs, we've got our CPUT University that we support, and thank you for all of you that are mentors for our students. The program is underway and there are currently 43 students. One of the students is the prize winner, Sister Hanlie Brewer. For CPD, I'm still awaiting the CPD points for March workshop. As soon as I receive it, the certificates will be sent out. The CPD has not yet been started by SANC. We are watching that space and we'll give feedback as soon as we receive some feedback. And then for this general meeting, you will receive a certificate of attendance if you have at least attended 75% of the session. So thank you. Enjoy the rest of the meeting. I'll see you on the 28th of May. Good afternoon, everybody. Sorry that I cannot attend the meeting this afternoon. My apologies. I've got 2,000 windows open. Okay, let me just get back to the meeting and reshare my PowerPoint. Almost there. Okay, Kola, I'm handing over to you. Are you?
Hi, Janette, can you hear me?
Hello. Yes, we can hear you. Can you see the screen?
Yes. All right. Thank you.
Okay.
There's no screen. Sorry.
Let me just share
I
again.
can see the screen.
Okay.
Let me just share again. I'm sorry about the mowing in the background. It's Spanner. He's our workshop cat. He came to visit us. So just don't mind him. Kola, can you see the screen?
Yes.
Okay, go ahead.
All right. Good afternoon, everyone. Thank you so much for actually making time to listen to us. Basically, on my side, there is much of a progress with regard to approaching the Department of Labor. We currently having, we're going to be having a meeting in the next month to look over and look into some perspectives with regard to occupational health in cooperation with Department of Labor. And we also having a meeting as well with DINOSE just to strengthen our relationship and partnership with other organizations. So, but so far so good. So that's all that I can give it to you for now.
All right, thank you very much. We're looking forward to that meeting. I think it's the start of great things, and we hope that it's happening very soon. Thank you for that, Kola. It took a great deal of effort to get that going. Right, Beverly, I'm handing over to you. Can you see the screen?
Janette, no, you can't display the presentation.
All right.
It's
so can
showing
I talk
on my screen.
Can I speak on your behalf for the first one? The second one is about the Somerset West shelter.
Yes.
Okay.
Yeah,
the
nothing
first
is
one.
showing on my screen.
All right. So the first screen that
is showing that Beverly can't see is a letter from Bless a Baby to thank us for all the knitted items. We've got a few of our members as well as members from the retirement communities in and around Cape Town that regularly donate knitted items for Bless a Baby, and they recently sent us a letter of thanks to say thank you and where all these knitted items go, and they ask us to please continue with this project. It's going very, very well, and as Joan says, it's more or less self-sustaining, meaning that we don't have to put in a lot of effort for this. It benefits everybody involved. It benefits the recipients, it benefits the givers, because I regularly knit these jerseys myself, and it's a great source of joy. It's something you can do while watching TV. It's just it keeps you busy. It's something that you enjoy doing, and I can imagine for somebody in a retirement home that's used to be busy, it's something that they really enjoy doing too. I know my mother also likes to do it. So Joan usually collects these items. Thank you, Joan, for that. That's probably the least enjoyable part of it, to collect all these items and go and deliver it to Bless a Baby, but we really appreciate that. And they also appreciate receiving all of it. As you can see from the photo, that's only a little bit of what was donated. So thank you everybody who contributes to it, everybody down the line up to where the people receive it. They are very thankful for it. The second one is the new project that we took on. The previous one was about Lily Rose, but we really struggled to get a hold of Lily Rose. It seems like they are receiving quite a lot of support already. So we decided to look for a new project, and Beverly came up with this wonderful project called the Somerset West Family Shelter. Beverly, do you want me to read through this? It's more or less what you wrote in your report.
Yes, please go ahead, because
Okay, you can't see it.
There's no
Okay.
presentation on my screen here.
All right, so
Thank
I'm just
you
going,
very much.
no problem. I'm just going to read. It's the only, it's sorry, I must have copied and pasted wrong. It's a new project that we will be taking on, and it's called the Somerset West Family Shelter. It's a one of a kind in the country, and it's an NGO. Families are referred by the Department of Social Welfare or social workers, and they are allowed to stay for up to 1 year. They are helped back into society with employment, a place to stay, and skills to help the families to survive. The shelter survives on donations like linen, clothes, toiletries, face cloths, nappies, and food. And there's also a creche with 13 children currently on site, and the children is taken to school daily. So how can you contribute? You can contribute by donating clothes, all the clothes that you can't wear anymore, that either doesn't fit or that you haven't worn in a very long time, or linen that you don't want anymore. Maybe you've changed your style, or the color of your bedding, or the children has moved out, or they've gotten bigger beds, or that it's been in your cupboard for a long time and you haven't used it. Toiletries, face cloths, nappies, and food, anything you feel you want to donate, please set it aside and call your caregiver or committee member that lives close to you if you have something to donate. We will arrange with you for collection and delivery to Somerset West Family Shelter. Please support this project. It's a very worthy one, and we will report back to you whenever we go to donate. It's I think it's a wonderful initiative, and it's a great way to give back to society. I've got a few sets of linen that's been, my family loves to dump things on me because they know I always find a place for it. I used to donate all the old shoes that the boys grew out of. We used to take it to the park runs because there's always boys from the informal settlements that likes to join the park runs. Now I can't do it anymore because my knees are shot. So now I sit with all the old shoes. A wonderful place to donate it to now. Okay, then last few slides. As you've noticed by now, the old WhatsApp group is closed. There's now a new WhatsApp group. It's called Sashon Western Cape Members 2025. It's a closed group. It's an exclusive group. You can only belong to the group if you're an active member with a recent 2025 membership certificate. If you want to be added and you haven't been added yet, please contact your caregiver or send me a copy or a photograph of your 2025 membership certificate, please, or proof of your payment. We need to make sure that we only add members that are eligible. And all communication previously sent via email will now be shared via WhatsApp. We find that the people don't read their emails. Everything that's relevant will be sent via WhatsApp. If you need something specifically to be sent via your email, please send me an email, even if it's a blank one. Just tell me in the message section or the topic section what you want. Otherwise, I won't know, and then I will send it to you. And there's a new WhatsApp feature where you can put down an invite for meetings or events. We use it now for our meetings. And I put in the link to the registration link to the Teams in there. You can use that to register for the event. I will show you when I'm done with this list where I pin it. And then the link to the meetings going forward will be in the WhatsApp group. And it's usually pinned to the top. So if you look there, this is a recent screenshot of the meeting. There at the top, there's a pin. And it says Sashon General Meeting, Epilepsy in the Workplace. Now, if you see the green bar, the small green bar to the left, there's two of them. It means that there's two messages that's pinned. If you click on that green bar, it will take you to whichever of the two messages you want to see, right? And then this is the QR code for the WhatsApp. For those of you who are a bit, if you want to scan this code, please go to the chat. The code will be in that chat if you can't scan it right now. Please join the WhatsApp group. It's really worth your while. All the recent news and messages and Sashon news and whatever is shared on there. All the new legislation that gets published, all the events, all the news, everything that you need to know about Sashon and what's going on there is published on there. So it's really worth will be a member of that group. All right, and as always, a thank you to the people behind the scenes, Serenity and Dorothy. You do the hard work, we appreciate it. And all the other committee members, a big thank you to what you do as well. Dorothy, shoot.
Can I talk?
You are very welcome.
Okay, good afternoon, everyone. Our great apology for all your frustration. We could read it on our group chat and in the present on the sideline and the chat. So there's definitely a problem for people who can't hear or see, or some people outside the meeting couldn't log in and they were really frustrated and say they give up. So we as a committee members will look into that. Just a few tips to see. Please, if you have difficulties, check your link. Just join in earlier so that we can see like 15 minutes before the time to see if you can log in. Check your internet, verify the link, check all the details and check your equipment, your internet. So I know it's frustrated and we are also frustrated from this side because not a lot of people could join in. The students of CPUT couldn't join in due to some challenges. So, but we as committee members will look into that and we will definitely do a dry run because it is frustrated for people that register and couldn't join in. Thank you.
Yeah. With technology is always a problem, especially if there's weather outside, it makes it worse. Okay, So this is the last slide that I shared. I don't know where it stopped sharing. If there's anything that you need me to go back to, there's one or two left. This is the list for the caregivers. If your surname starts with that letter, just look at that row, and that's the person who is your caregiver. And that's a person that you should contact first if there's anything you want to find out. That person will then, if they can't help you, raise it with the committee. And if the committee can't resolve the problems, then I will contact the head office on your behalf. So please contact your caregiver first. If they can't resolve it, then we will help you further. It's also on the WhatsApp group right at the top. You will see it right at the top under description. Your caregiver's name will be there. Right, so there's no reason not to know who your caregiver is. Okay, and if you need to contact the head office for membership queries, Adele is the person to speak to. Remember that they only work half day. You won't find them in the afternoons. If you have audio requests or audio queries, you can contact Geeta. Please remember that session membership and audio membership are two separate things completely. If you have a membership for the audio, so if you have audio registration, you're not yet a member of session. Those two are separate. If you are a session member, it doesn't mean that you automatically have an audio membership. Those two are separate entities. All right. And this is at the bottom is the physical address. If you need to know anything about Sashon, there's a lot of information on their website too. And that's my story. Thank you everybody for joining us. It was very nice having you here. And that's the end of the meeting. Thank you. I ask the committee members just to stay behind. There's somebody who wants to ask a question. Just give me a sec. Just give me a second so that I can. Yes, you can ask your question. Just unmute yourself.
Hello, can you hear me?
Yes.
Hi, I'm sorry to ask this on this platform, but I'm looking for some way to do the family planning course, contraception, but I don't seem to find any platform at the moment in the Western Cape.
Kobanashi, there's a very nice place you can do that. Let me show you.
Okay.
I'm going to share my screen as well,
Thank
and it
you.
doesn't cost you anything.
Okay, awesome. Thank you.
So you go to Knowledge Hub.
Oh, okay.
Have you been there before?
I've been there, but it was giving me all the old information. Maybe I have the wrong email.
Now go to knowledgehub.health.gov. Just type in Knowledge Hub, and then you go to courses, and you go to the sexual and reproductive health and rights training.
Okay.
Now, this module 5 is the modern contraceptives. That's the one that you need to do. You don't need to do the whole thing.
Oh,
It will take you weeks. You only need to do module 5. And when you're done with that, you print a certificate, and then you're done with the family planning. We've my whole team has done that.
Okay, awesome.
And that's basically all you need to do. And Joan's team, her people has done it too, and they were successful with getting the family planning done.
Thank you for that. Appreciate it. Thank you. Have a lovely day.
You too. Listen, give us feedback on that. If you apply for, we've gotten our licenses with that too. So if you've done that and you get any problems from clinics getting your medication and so on, please let us know, because we advise this as the family planning course to do, but if it gives you any problems, please let us know.
Will do, will do. Thank you very much. Have a
On
lovely
that
day.
note, if there's anybody that works in the Grabouw area, I've just learned that they accept PRDP medical forms completed by occupational health nurses in the Grabouw area. So occupational health nurses they will take the PRDP forms if you fill it in. It's good news, eh? All right. Now the meeting is really over. Let the committee meeting, the committee members just stay behind, please. Thank you all. Hallo Joan, ek is jammer ek moes jou lankal al 'n presenter gemaak het. Sorry man.
Ag nee, dis alles reg. Jy het goed genoeg aangegaan sonder dat ek inmeng. Ons kon net aan hierdie kant niks sien nie. Toe jy al jou skerms toemaak, dis dit vir die eerste keer wat ons iets kon sien. En snaaks is that Serenity then couldn't see anything.
Weet jy, tegnologie maak my klaar. Ek kan nie meer nie. Regtig, ek is baie lus om weg te hol.
Ja. Toe maar ek weet hoe jy voel.
Janet, I could see your screen.
Is it?
So I don't know. Yes. I could see your screen.
Ja,
Daar's nog mense in die vergadering.
Dis reg, ons kan hulle maar
I was just hearing voices on my side. It took very long for my screen to actually work.
It's okay. I
could actually see most of the presentation. It was just here at the end where, concerning the care list, where Joan shared the picture. That's on my side. I couldn't see again. And then there was quite a few people that I admitted late. While the presentation was going on, there were still people in the lobby. So I've been trying to admit them. So there's a picture that I've seen where I couldn't actually see anyone that was still waiting in the lobby. So I don't know where the connection problem really was.
Yeah, I see a message now from Natalie to see that the students struggle to get in.
Yeah.
I'll reply to her, but I don't know. I really don't know anymore. I don't know.
There was quite a lot of members today that couldn't log in.
Yeah.
You know, they gave up halfway. So,
Yes.
you know, maybe we should allow people to enter at 1:45.
Yeah.
So that by 2:00 when the meeting starts, at least they're in. So, you know, because I also only entered very late, so I missed half of the presentation because we were also waiting in the lobby.
Sure. Do you think there's a backup in the lobby?
Janet.
Yeah.
Can I just ask something? So are you making everyone presenters? I'm not sure if maybe because I started the meeting and then a lot of people got into the meeting. So I started from this side. Did you also started the meeting from your side also?
No, thank you for that you started it. I tend to forget.
I started at 4:10, 2:10, and then and Dr. Greg was already on. So I'm not sure if that was the case also, maybe because it wasn't started from your side.
Yeah. Thank you. You know, I tend to forget that, and that's the recording only starts when the meeting starts. So I have to make a mental note of that every time, and then I get distracted because there's 2 million things happening. But anyway, So maybe that's between you and me, we can I'm glad that you can do it as well. I didn't know.
I can start the
Janet?
meeting. Sorry, quickly.
Yes.
I
Dorothy?
can start the meeting, but I can't let people in. So I don't know. I don't have a let in button or somewhere.
Okay.
Admitting the
Janet,
people.
sorry guys, but who's this Anthony Jacobs that's still on the group in
It's
our meeting?
Beverly.
Is it Beverly? Okay,
Yeah.
thank you, Beverly.
Oh, it's a Beverly.
Yeah. Okay. If
I'm
there's
still
nothing.
here.
Yeah. Thank you, everybody. There will be hiccups with every online meeting. It's high technology, and there will always be problems. But I think we managed well. So, and as we use more and more technology, it will just get more complicated. But we're right with the waves. So, thank you, everyone, and have a wonderful holiday tomorrow.
Okay.
And
Thank you,
I appreciate
Janet and
your hard
team.
work.
Thank you.
Thank you,
too.
Janet, and
Okay,
well done.
bye.
Bye-bye.
Bye.